I'm going to ask questions after my lecture because usually human mentality is no lecture is understandable beyond 20 minutes. So I'm going to ask question after 20 minutes. I'm going to give 3 lectures in the field of hand surgery. In before that, I would like to know how many of you are first poster CPS. Okay, this is your first post of CPS. Second post? Okay, and final year? Okay, fine. So usually in MS or CPS or any DNB, hand surgery, there is no long case and there is no long question. So usually we have multiple short notes like hand fractures or metacarpal fractures. It will be always a short note, or say radial nerve palsy, it will be a short note, or it will be a short case in your exam, and it is 100% scoring subject. But in hand surgery, it can be all or none phenomenal. If you know, then it is 100% correct. But if you don't know, it is 100% wrong. So if I ask you a question of or talk 2 minutes about peripheral nerve injury, then either you know or you don't know. You cannot bluff in hand surgery because it is very visible. You should not worry too much because most of your examiners also don't have that much knowledge about the nerve injuries, because all orthopedic surgeons, they deal with trauma, but nerve is totally a different ball game. Okay, so to my topic, they have told me to talk from 10 o'clock to 12:30, but I will finish my talks in 20 minutes, and then we will have some discussions, because otherwise, for if you go and read your Campbell or Rockwood or any trauma related textbook of hand surgery, impossible to grab the things, and then finally you will end up reading something non-specific. Okay, with this background, let us understand about hand fractures. First of all, the difference between monkey and human is monkey has 5 fingers and human has 4 finger and thumb. So thumb is the most important aspect of our function of the hand. If the function of the thumb is absent, or somebody has amputation of the thumb, 50% of his hand function is completely compromised. So thumb is extremely important. Now, to simplify our understanding, first of all, let us understand the hand has 3 phalanges. Every digit has 3 phalanges. Distal phalanx, middle phalanx, proximal phalanx, then we have metacarpals, and then we have carpal. I have not included carpal injuries in this talk. So in the phalanx also, either we have fractures of the shaft of the phalanx, or we have fractures around the joint, like distal interphalangeal joint or a proximal interphalangeal joint. So that is called fracture in a periarticular fractures. In that also, either we have base fracture or a condylar fracture. So if you understand, this is the base of the middle phalanx and this is the condyle of the proximal phalanx. So treatment of both of this is different. Okay. So this is a base of middle phalanx and this is the condyle of proximal phalanx. Okay, so the treatment of each of them is completely different. Now there can be open fractures in the hand, especially industrial accidents, गन्ने के जूस में हाथ आ गया, और punching machine injury or a roller machine injury. So open mutilating injuries in the hand are extremely difficult to treat. Here in the hand there is no fat. So either we have skin, then we have extensor tendon, then we have bone on the dorsum. On the volar side, we have volar skin, we have flexor tendon, we have bone, and on the either side we have digital neurovascular bundle. So beyond this, there is no anatomical structure present in the hand. Whatever we do or whatever nature does, stiffness in the hand is permanent disability. It is, you have to take care of it very seriously, and it is not like we have a simple phalanx fracture and we put 2 K wires and then after 1 month we check a x-ray and remove wires and start movement. They don't move that way. You have to, the patient, the best patient is if they keep a follow-up with you for 3 to 4 months, then only they can get a normal hand function. It is very easy to get a good function after a humerus fracture or a radius ulna fracture, because there are a lot of muscles around. So there is absorption of the soft tissue, and then movements is multi-directional. In the hand, it's a hinge joint. Movement is possible only in one direction except the thumb. Thumb has circumduction movement. Okay. So because it is impossible to cover everything in half an hour, these last three I am not going to cover. Open fractures, fractures in children, and chronic or malunited fracture, because it's a different lecture. At your understanding, if we understand first two, that is the success of our lecture. So these three we are not going to cover today. Now, what are the most common mechanism of hand fractures? Cricket ball injury. The most common, you get a mallet injury or you get a fracture of the PIP joint. It is because of while catching in the cricket also, bowling, batting and fielding and wicket keeping. So wicket keeping and catching while fielding, these are the two most common mechanism of injury to get a hand fracture. Then we get an industrial or a domestic accident, mixture injury or any machine injury. Then of course a vehicular accident, and then trivial fall in an elderly population. While getting up in the bed, they just slip their hand and they get a fracture in the shaft of the phalanx. Now let us treat one fracture, that is shaft of the phalanx. So what are the different types of fracture? It doesn't change whether it is a humerus or femur or a phalanx. So usually we see a transverse fractures in the hand, okay, in the phalanx of the shaft. Then we see a oblique fracture in the shaft. Then we see a spiral oblique fracture in the shaft. Okay, these are the most common type. So the treatment for everything is different, because in the shaft fracture or the transverse fracture, there if we understand the orthopedic principles, we should have a absolute stability. There should be no movement at the fracture site. Then only this will heal, because there is less soft tissue around. When we see a oblique fracture like this, as shown in the middle X-ray, the oblique fractures, they usually very unstable fracture. Even if you fix them, they rotate. And then there is a spiral oblique fracture. The commonest component, if you treat this fracture inadequately or inappropriately, whenever person makes a fist, it rotates inside. They get a rotational deformity. So these fractures have to be treated very well in time. Now, which fractures we can treat non-operatively? So conservative management. When there is no rotational malalignment, how do we diagnose that? Whenever we ask the patient to make a fist, if the patient is able, all four nails or full pulp, if they touch well on the palm, that means there is no rotational malalignment. If somebody does it like this, if all four nails are not visible or one finger is tilted inside or outside, that means there is a rotational malalignment. However undisplaced these fractures are, if there is a rotational malalignment, we have to fix them. I will give an example for that. And then displacement on adjacent joint movement. If the fracture is there, then under CM you ask the patient to move the finger. If the fracture is not moving, then you can treat them in a body strapping or a slab. If associated joint is not dislocated or subluxated, then you can treat this fracture without surgery. And not more than 30-degree angulation. I will show you that in an example. And not more than 10-degree angulation. We don't accept more than 10-degree angulation at the shaft of the fracture and 30-degree at the neck fracture. So let us now take distal phalanx, then middle phalanx, then proximal phalanx fracture. Before that, any questions? Do we know three types of important hand fractures? Transverse, oblique and spiral oblique. Hand fractures are classified as per either they are in the shaft or they are adjacent to the joint. This is the simplest classification. Then you can have open fractures, you can have fractures in children, and you can have pathological fractures also. Okay. So now let us take distal phalanx fracture. Can anybody, do you remember what are the most common mechanism of fall or mechanism of getting hand fractures is cricket ball injury. Don't forget, because that's hand and face. These are the only two exposed structure of your human body. We are all only exposed structure is our face and hand. So very easy to get injury. Okay. So cricket ball, domestic accidents, vehicular accidents. These are the most common problem. Now let us take one example. So you will get this as a short note, and at least when you start your practice, one patient a month you will see with this kind of fracture. So what is the problem here? If you see, it's a cricket ball injury again, and if you see, there is a fracture here. Okay. Now in the finger, around the fractures around the joint, if I ask the patient to flex your DIP joint, there is a flexor tendon which is attached on the base of the mid distal phalanx. And if you ask the patient to extend the finger, there is a extensor tendon attached. So usually such fractures are avulsion fractures. Okay. But then indication to treat this fracture is if the joint is not subluxated. Here is the joint subluxated? No. So we don't need a operative treatment. Second indication, is the displacement more than a 2 millimeter? I don't think so. Is there any angulation at the fracture site? No. So this fracture can be treated conservatively. Usually nowadays we get a ready-made splint called mallet splint. It is available in any medical store. But I treat them in a cast, and I keep taking 10th day X-ray, because by Indian scenario, if you ask the patient to stand, they will walk. If you ask the patient to walk, they will run. You understand? So if you ask the patient to wear a splint 24 hours, they will wear it 2.4 hours. So we don't trust the patient. Okay. So we treat this, I have treated this patient in a plaster, cylindrical cast to the finger. And then if you see the X-ray in the cast, the fracture is well aligned and the deformity is corrected. Mallet deformity is like a mallet, like a bending deformity. So you have to give a cast in extension of the finger. But this cast can become very loose, or if you make it very tight, it can hamper the blood supply of the finger. So you have to call these patients frequently in your clinic to check the vascularity. And this cast can be loosened, it can come out. So sometime you have to keep the PIP joint in flexion. Like this we need to give the cast so that it doesn't come out. And this has healed very well. Now take another example. So again a mallet injury. Now you see the fracture is definitely displaced. Of course the joint is not subluxated, but here the fracture is rotated. Now this fragment should be here. It is a rotated fracture. Okay, so such fractures needs fixation, because once they heal, the flexion is not going to be possible, because extensor tendon is attached to this fragment. Unless this fragment becomes the part of the parent bone, it cannot cause extension of the digit. So such fractures we can treat them with the screw fixation. Okay, this is the one single small 1 millimeter screw fixation. You can put wires also. There is no need to put a screw, but screw gives best stability. Wires can be loosened. There is a small risk of pin track infection to the wire. So that's why I treat them in the screw fixation. So mallet injuries can be treated conservatively and can be treated operatively. Okay. Now let us take example of a middle phalanx fracture. So can anybody tell what kind of fracture is this? So whenever somebody is asking you this question, first of all, please switch on your button of your brain. This is a fracture around the joint. That is number one classification. Which joint? Distal interphalangeal joint. Now whenever we see a fracture around the joint, either it can be a base of the fracture or it can be a condylar fracture. Base is a base, condyle is a head. Is this a base fracture or a condyle fracture? Condyle fracture. So which condyle? Middle phalanx. So distal condyle of the middle phalanx. Okay. And then now so classification is very clear. If you see this X-ray in the casualty, and if you call your senior or boss, there is a X-ray, I mean there is a ring finger injury, and I can see on the X-ray intra-articular fracture of condyle of middle phalanx right ring finger. He will be very, very happy. Okay. Now, is it undisplaced or moderately displaced or mildly displaced? Mildly displaced. So will you treat this conservatively or operatively? Conservatively. All wrong. Okay. Because another one criteria, however conservatively, however undisplaced fracture you see, if there is a rotational malalignment, these fractures need fixation. So whenever somebody asks you this question, will you treat this conservatively, or first of all, I would like to see the patient clinically. What do you want to see in this patient? Number one, is it an open fracture? Then you need surgery with debridement and fixation. Then second, rotational malalignment. I want to ask the patient to make a fist. Now when we ask this patient to make a fist, now this is very simple fracture. If you do a body strapping, this will heal. But then if you ask the patient to see this is how he is making a fist. So this is not acceptable, because if you accept this fracture is going to heal in this position, which is a deformity in a 23-year-old girl, which can be 100% correctable. You understand? So however undisplaced fracture it is, you have to see rotational malalignment. This is completely rotationally malaligned, and then we fix it with simple 2K wires. And then the rotational deformity is completely corrected. Any confusion? No. Let us take one more example now. It is what? Blunt injury to the index finger. Yes, doctor, which X-ray will you advise? X-ray. This is the index finger swelling. Any X-ray? Hand AP and oblique. How many will of you advise hand AP and oblique X-ray? So this is the hand AP and oblique X-ray. Yes, any comment? So whenever you see a fracture from proximal phalanx to tip, please do not order hand X-ray. Please order finger X-ray. If you have multiple finger injuries, do not order hand X-ray. There is a way. You know, when we say somebody, you look beautiful, this is the way in which you should take a X-ray. All three fingers can come as a lateral view like this. Okay? Because many times we argue that if there is a one finger injury, you can take lateral X-ray and AP X-ray. But if there are two finger injury, and if you do lateral X-ray like this, they will overlap and we will not come to know. So two finger X-ray, we do X-ray like this. Suppose this is the plate, this is the X-ray. If there are three finger X-rays, we do like this. Okay, swan neck, we do like this. If there are four finger X-rays, four finger fracture, we do like this. So please remember, finger injury, or if there is a confusion, please stand there and take multiple finger X-rays, lateral X-rays. So this is completely, is there any information that you can make out? You can make out just there is some fracture at the neck of the index finger or middle phalanx. But if you take a proper X-ray, see this. Is that very clear? It changes the complete treatment. So orthopedic surgeon only after seeing this X-ray had given a body strapping for 10 days. Patient understood there is something wrong because the condyle he was feeling here, it was palpating. So he understood there is something wrong with this strapping. I will not become all right. And then he came to us and we took a dead lateral X-ray of finger, AP and lateral X-ray. See this. This is complete. Now, yes, doctor, can you please read this X-ray? Yes, yourself. Yes, please. Can you read this X-ray? You read anything. Just read this X-ray or this. What is this X-ray? If this X-ray comes to you in exam, can you read it? Okay, accepted. What do you see in this? Is it a shaft fracture? Or it could be a neck of middle phalanx. Okay, and it is displaced. The head of the middle phalanx is, fallen down. So it's a displaced, volarly displaced neck of middle phalanx fracture, right index finger. Is that clear? It is possible to comment on X-ray only if you take a finger X-ray. Is that clear? Now, does it need conservative treatment or operative treatment? operate. So you can still treat these fractures in a conservative manner, but then you have to keep a close watch. There is a procedure called Jahaz maneuver, JAHSS. Usually this is done for neck of metacarpal fracture. What do we do when, I will show you in the x-ray, but such fracture, now you have a condylar fracture, you bend the distal phalanx completely and press. So this fracture, this condyle we press from volar side with your thumb push, and it can realign here, but it is very well, it can get displaced. So the treatment is very clear. First you reduce it and then put a axial K wire. Just put a longitudinal axial K wire. Don't remove it for 2 months. No stiffness, nothing. Once the fracture heals beautifully, you remove K wire, then start the DIP joint movement. Okay. So with this injury, the message is finger injury, finger X-ray. Metacarpal fractures, hand X-ray. Okay. So let us take one more. Now, yes, doctor, can you make out on this anything? What is anything that you can make out? If you can't understand, you can tell I don't know. Okay, there is a, I am giving you a hint, trauma to ring finger. Yes, what is the next step, madam? What will you like to do now? Okay, so this is the ring finger X-ray. Can you read the X-ray? Please read the X-ray. Yes. Yes. So please remember, now I would like to explain you a small anatomy of the hand. So you in the hand, okay, in the hand we have distal phalanx. I am drawing a lateral view. Then we have middle phalanx, proximal phalanx, and then metacarpal head. Okay. So middle phalanx, this is the dorsal side, this is the volar side. Is that clear? Here we have one tendon attached. It is called extensor digitorum communis. Action of this tendon is DIP joint extension. Is that clear? There is a tendon attached here. It is called flexor digitorum profundus. Action of this is flexion of DIPJ. There is a, this is distal phalanx, middle phalanx, proximal phalanx, metacarpal. Then there is a tendon attached here. It is called central slip. Function of this tendon is to extend DIPJ. Extend DIPJ. I will explain you. Then there is a tendon attached here. It is called flexor digitorum superficialis. Function, flexion of proximal interphalangeal joint. Then there is